Good morning. Just this week, Dr. Jim Rutka was given the highest civilian honor in Canada by being made an Officer of the Order of Canada, and we're thrilled that he's here with us today to talk about recent advances in epilepsy surgery.
So thanks very much, Steve and Brian and Jim and Russ. Congratulations on your meeting. It's a real pleasure to be here today to tell you a little bit about some recent advances in epilepsy surgery. I'm going to do so through an explanation of some of these abbreviations that are on the screen that you can see there, so I'll be doing that in the next few slides. I have nothing to disclose that's relevant to today's lecture. Well, here are the abbreviations about which I'll be speaking, and you can see them all listed here. The one that's not in the program book is the one at the bottom, BOSD, which stands for bottom of sulcus dysplasia, which I'll be describing in some detail. Well, I really like epilepsy surgery because it allows the neurosurgeon to come in contact with virtually every condition that's known to the neurosurgeon. And while in epilepsy surgery we concentrate on those that are in the lower left-hand corner here, the malformative lesions, you can see that the epilepsy surgeon is really dealing with virtually every condition in the brain, including trauma, which we just heard about from Jeff Manley today. I'll start first with a description of MEG. What you may not know about MEG is that it has the best spatial and temporal resolution of all the imaging studies that are available, and we've been using it since 1995 at the Hospital for Sick Children. To show you some information about characterizing magnetic spike source imaging, so we've defined the cluster, the small cluster, the scatters. We've been able to publish our data to know what is really an important finding with respect to MEG spike clusters here in work in the Journal of Neurosurgery. The trouble with MEG is that it's an interictal data point, if you will. And so on occasion, however, you can get lucky. You can get an ictal MEG. And here's an example of an ictal MEG in a patient who has EPC and is having continuous seizures. So in the MEG apparatus, the MEG showed these spike clusters here. And of course, the treatment for that is hemispherotomy. We've also been able to describe image-guided removal of MEG spike clusters, so obviating the need to go to invasive monitoring. Here's a child who had post-traumatic encephalomalacia, you can see in the right parietal area, but there's this spike cluster shown by the arrows here. Resecting the spike cluster by itself can lead to seizure freedom in work that we've also published recently. MEG is very good at functional mapping, so it can allow you to distinguish the somatosensory cortex and the motor cortex and tumors that might straddle the distance between them, as shown there. What you may not know about MEG is you can also map the visual cortex. Here's a 12-year-old male who has visual seizures. You can see the lesion in the parietal cortex abutting the occipital lobe. There's the visual evoked field shown by the arrow in the right-hand panel. At the time of surgery, you can see by ultrasound we can characterize the lesion and we can remove it. This child now is seizure-free. We've been able to spare the visual fields because the lesion was sitting above the calcarine cortex, and we had all this information heading into surgery. Okay, next is the intraoperative neural monitoring and brain mapping in epilepsy surgery. This allows us to identify which structures are at risk by mapping the primary motor and somatosensory cortex and differentiating between functional and non-functional neural structures. Also allows us to monitor structures that are at risk in order to prevent neurological impairment and to have our neural monitoring technicians advise us as to when we might be running into some danger. Here's Sam Stranzis. He's our lead for intraoperative neural monitoring at Sick Kids Hospital. Over the years, we've had a number of publications that illustrate the way in which neural monitoring and mapping have helped us in epilepsy surgery. More recently, we published on the use of awake craniotomy in children. And so we've been using this technique on occasion, not so much now, but when needed, particularly to map language function in children as young as age 4. Of course, to do that, you need to have excellent help by your neuroanesthesiologist and also a neuropsychologist in the operating room at the same time. Modalities that are specific that we use for epilepsy include phase reversals, direct motor cortex stimulation, subcortical stimulation, and for monitoring, you can see continuous direct cortical stimulation and EEG to look at stimulus-induced after discharges. There are two primary techniques for motor cortex mapping. There's the Penfield technique and also the train technique. We've been using the train technique the last 7 years. The difference between the two has to do with number of pulses that are given, the Penfield technique having a higher number, 600 or more pulses, whereas the train technique, 5 to 7 pulses. What's interesting is the chances of inducing a seizure is much higher with the Penfield technique at the time of surgery than it is with the train technique. And monitoring the cortical spinal tract is only possible with a trained technique and not so much for the Penfield technique. Here's another publication from our group that illustrates our use of the trained technique. Well, many of you have done surgery, you've had your neuromonitoring team there, and you'll be operating, and then suddenly the neuromonitoring technician will tell you that you've lost your evoked potentials here. Here's loss of the motor evoked potentials as you're doing a case. This was an epilepsy surgery case, and it was due to excessive brain retraction. So by stopping everything you're doing, by irrigating the field, and by waiting some time, you can get, and by releasing the retraction, you can get return of the motor evoked potentials. But that's a long pause in the time of surgery, and of course, surgeons worry a lot about that issue. But having a technician there who can tell you that you're potentially running into trouble when mapping the cortical spinal tract is very important. Okay, subcortical stimulation and its benefit during epilepsy surgery. Here's a case of a child who has polymicrogyria. You can see the expanded periinsular region here with the thickened cortex. So the cortical spinal tract is here. So as we're resecting that periinsular cortical dysplasia and polymicrogyria, you can see how close you're getting to the cortical spinal tract. So it's really nice to be able to do subcortical stimulation in these types of cases. Okay, the next abbreviation is high-frequency oscillations. What are they and how are they measured? This is an image showing what they looked like at the time of surgery. The normal brain has a rhythm of about 30 hertz, so there's a faster rhythm in the brain characterized by these ripples that can be anywhere from 80 to over 200 hertz. These are detected by invasive subdural grid monitoring. The presence of them are detected by EEG, and they precede clinical seizures. And resection of these cortical regions can be extremely important in getting good outcomes after epilepsy surgery. Here's a video that's showing you how the brain, this is a real-time animation of how the epilepsy discharge arises by virtue of these HFOs in the brain during subdural grid monitoring. We've had a number of publications in the field that have allowed us to explore the value of HFOs during epilepsy surgery. This has become a very important technique for all of us. It has some limitations. We really don't understand what the basis is neuronally for what HFOs are. On occasion, normal cortex can elicit HFOs, and we have really at this stage no long-term data. But this is the current model of how HFOs work in the brain and how they create epileptogenesis. For this audience, I don't need to talk about this abbreviation, which is, of course, diffusion tensor imaging. I know all of you are using this in your own centers as you're doing your cases for tumors, for epilepsy, and so on. Here's a case of a child after hemispherotomy with recurrent seizures, and the arrow is pointing at a zone of persistent connectivity, which was fairly straightforward to go back in and disconnect completely in work that we published recently in the Journal of Neurosurgery. But this strategy is extremely important when linked to neuronavigation and neuromonitoring. These are different epilepsy cases that you can see in yellow, the cortical spinal tract, functional parts of the brain, and in pink, the lesions. So our neuroradiologists will draw out the lesions for us in juxtaposition as to where the cortical spinal tract is, and we get a great map of how we can approach surgery. And again, linking things to our adjuncts help us to do the surgery much better. Okay, this is bottom of sulcus dysplasia, which is a fairly new and recent term that some of you may not be familiar with. Basically, it's a type of focal cortical dysplasia type 2. These are very subtle lesions and only recently have been identified by high Tesla MR, and using 3 to 7 Tesla MR, you can pick up these lesions that occur like this that you can see in the brain. But quite frankly, you need almost an experienced neuroradiologist to be able to see some of these. Here's a work that we published recently. So here's an example of several cases that we've operated upon that have bottom of sulcus dysplasia. The images are not so crisp and clear, but you'll trust me on this that, in fact, these are areas of suspected dysplasia. Sometimes they're so subtle that we can't be sure prior to surgery, so we often go to invasive monitoring for these types of cases. Here's a case I'll be facing when I go back to Toronto next week, a child who has in pink an example of bottom of sulcus dysplasia embedded in the motor strip, embedded in the cortical spinal tract. So we'll be doing invasive monitoring to work this out to see if this child can have resection of that lesion in a very eloquent part of the brain. Okay, I'm going to finish with about 3 examples of putting all of these technologies, all of these abbreviations together for the benefit of helping patients with epilepsy surgery. And so, first case is a 4-year-old dominant hemisphere lesion. You can see on the MRI scan how close this lesion gets to the cortical spinal tract that's shown here. Because we were unsure about where language was situated and a child was a little bit young for awake craniotomy, we went ahead for invasive monitoring. At the time of the exposure, you can see the lesion is located here between the letters D, E, F, G. Motor strip is back here in the parietal area. And we did the workup. We have this kind of a map. Again, we put both depth electrodes into the lesion and surface recordings on top to see how much area around the lesion might be affected by epileptogenesis. Here's the seizure. This is a 4-year-old. The grid is in place now, and the child is reaching for her right hand, and her right side of her face is fluttering. This is a simple motor seizure, but she would be having dozens of these every day related to that lesion. Here's the HFO that indicates precisely where the seizure onset zone is located. You can see the depth electrodes going into that area. And here is the animation in real time that illustrates how the brain is firing by virtue of expression of these HFOs. Here's now the seizure surgery plan. There's the resected area proposed in yellow. You can see the outline that's traced out. Here after surgery, resecting the lesion, you can see leaving the veins that are en passant so as to avoid venous edema or swelling afterwards. The arrow is pointing at an electrode array that we're keeping on the surface of the brain over the motor cortex that allows us to do continuous train recording of the motor strip to avoid any kind of injury afterwards to the cortical spinal tract. But interestingly, even though everything was fine during surgery, this child was immediately dysphasic and had a right hemiparesis. Thankfully, that all improved within a week, and the best news was this was an example of cortical dysplasia with the balloon cells that you can see there in the neuropathology. Okay, the second case, targeting a small focal cortical dysplastic lesion. There you can see it in pink with the arrow pointing at it just in front of the cortical spinal tract in a 10-year-old male who had failed multiple medications. Here you can see the arrow is pointing at depth electrodes and surface electrodes that we're using to characterize not only the seizure onset zone, but its spread to surrounding brain. Here we are placing a depth electrode using neuronavigation right into this very subtle lesion that you can see that's traced out here. And then we use the depth electrode at the time of the second operation, remove the grid, follow the depth electrode to the area of the cortical dysplasia because these lesions are subtle and they aren't trivial in terms of their localization. So using the depth electrode, we've been able to find these lesions, resect them, and patients have done extraordinarily well with these very subtle lesions that cause sometimes explosive epilepsy. Okay, in the final case, so removing a lesion in a critical zone. Here you can see on this MRI scan a rather fuzzy lesion that's indicated parasagially, 4-year-old male with intractable epilepsy, right leg seizures. Here's the map you can see in pink. So this is sort of tucking into the cortical spinal tract. So access to this and removing this is somewhat of a challenge. You don't want to go too far laterally as you're resecting these so as to avoid injury. During invasive monitoring, we placed 2 depth electrodes into the lesion and an interhemispheric strip, and we approach this through an interhemispheric approach as is shown here. So there's the lesion in this 4-year-old child, and here's the video showing the resection of this using the interhemispheric approach and the cavitron, and you can see these lesions have a different texture to the surrounding brain, but they're not exactly like tumors. They don't have a well-demarcated zone, so you have to be very careful as you're resecting these, and using neuromonitoring all the while and staying on target with your neuronavigation leads to excellent outcomes in children with, like this, and this child now just recently, so 4 months out, neurologically intact. Okay, so in conclusion, advances in epilepsy surgery about which I've spoken this morning have been possible mainly because of the advances we've had in imaging. And now we see these very small lesions I talked to you about, the bottom of sulcus dysplasia that we could never see before. We've had advanced MR sequences now linked to our neuronavigation platforms. We have both surface and depth electrodes, and I should mention that in North America now there's a move afoot for many centers to move towards stereo EEG, that is using depth electrodes solely. But we still find a combination of surface and depth electrodes to be the most important for us in terms of getting the information we need to get a child seizure-free. We've characterized safe resections even within the Rolandic region, and we've seen that seizure onsets can be detected using high-frequency oscillations, the ripples and fast ripples. And finally, the neuromonitoring that we use, the awake craniotomies and so on, have all come into play together to help us achieve the results that we want. So I just want to close by saying I really like Russ's logo for the meeting, which is Advance, Adapt, and Achieve. In the title of my talk, I've talked about advances in epilepsy surgery and how we've been able to achieve best outcomes. This is not a single person's ability, however, to do these types of cases. You need a full team, and I want to close by acknowledging the team that we have at Sick Kids that allow us to do these types of very interesting, very challenging, but also very rewarding cases at the Hospital for Sick Children. So thank you very much.